Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I am a cardiologist. I have been in practice for more than 30 plus years at the Texas Medical Center in Houston, Texas. Today we are going to talk about constrictive pericarditis. So let us begin. Constrictive pericarditis is a condition where there is increased thickness of the pericardium which restricts the ability of the ventricles to respond to hemodynamic changes, particularly in preload. A little bit about anatomy of the pericardial lining of the heart. Here we have a cross section of the entire thickness of the heart muscle. The inner lining consists of the endothelium. Then we have layers of muscle bundles. Surrounding that we have the visceral pericardium, and beyond that we have the parietal pericardium. There is a tiny space between the visceral and the parietal pericardium which is filled with a thin layer of a fluid which is no more than 30 to 50 ml. This fluid and the pericardial sac separates the heart from the surrounding structures such as the lungs and the mediastinum. It acts like a shock absorber for the heart. It prevents the heart muscle from getting bruised during each heartbeat. Let's talk about the pathophysiology of chronic constrictive pericarditis. There is increased thickness of the pericardium surrounding the heart, which is fibrotic and calcified, which acts like an iron jacket around the heart chambers, thus restricting the diastolic filling of the left and the right ventricles. As a result of that, there is reduced end diastolic volume, which leads to reduced cardiac output, and the ventricles also fail to relax completely because of the constriction. One of the characteristic findings of constrictive pericarditis is the abrupt reduction in the late diastolic filling due to the inability of the ventricles to expand with the increasing preload. Let's talk about etiology. In most cases, the etiology is idiopathic. Sometimes it may be related to a viral infection. It can happen following myocardial infarction or cardiac surgery, and it is also seen following radiation. The other causes of constrictive pericarditis include chronic renal failure, connective tissue diseases, and very rarely tuberculosis, at least in the United States, and malignancy can also be a cause of constrictive pericarditis. But in majority of the cases, the etiology is idiopathic or post-cardiac surgery or related to radiation. Generally, it starts off as an acute pericarditis, which is followed by effusive pericarditis or fluid collection in the pericardial space, which later on organizes over a period of many years. This is followed by fibrosis and adhesions, leading to calcification and eventually something that looks like a cast around the heart that culminates as constrictive pericarditis. The symptoms of constrictive pericarditis are very minimal. Occasionally patients may have chest pain, but more importantly the symptoms are related to the reduced cardiac output. Like in patients with chronic heart failure, the patients experience weakness and fatigue, lack of energy, and some patients may experience weight loss and cachexia. So on physical examination, we need to look for weight loss and cachexia. There is increase in the jugular venous pressure due to the impediment to the venous return in a patient with constrictive pericarditis. We will talk about increased X and Y descent in the jugular venous pulse pressure in patients with constrictive pericarditis. These patients may also exhibit paradoxical pulse. Occasionally you may be able to hear a pericardial knock. Pericardial rub is sometimes heard. A small sign may be present in patients with constrictive pericarditis. The lungs fields may be clear, or you may hear some rales and wheezing. There is generally hepatomegaly because of venous congestion, and similarly the same thing accounts for abdominal swelling and leg edema. Diagnosis is based on a history, examination. EKG has very little contribution in terms of diagnosing constrictive pericarditis. Chest X-ray can show some evidence of calcification in patients with chronic, long-standing constrictive pericarditis. Echo and Doppler findings are exceedingly important in helping us to identify the presence of hemodynamic limitations related to chronic constrictive pericarditis. CT and MRI are excellent for identifying the thickness of the pericardium, the presence of calcium, and also the texture of the pericardium, so that it will help in terms of surgical management. Cardiac catheterization can confirm the diagnosis of constrictive pericarditis and help us to differentiate between constrictive pericarditis and cardiac tamponade. And hemodynamic evaluations will also help us to identify the impaired diastolic filling of the ventricles. Let us look at some differences between tamponade and constrictive pericarditis. Paradoxical pulse may be present in both these conditions. Similarly, the equalization of the pressures in the right and the left heart chambers may be present in both these conditions. The main difference would be the venous waveform. In tamponade, there may be absent or diminished Y descent, whereas in patients with the constrictive pericarditis, we can see prominent Y descent. The inspiratory changes in venous pressure are decreased in patients with tamponade, whereas there is no change in patients with constrictive pericarditis, which is referred to as Kussmaul sign. No change in inspiratory changes in the venous pressures in patients with the constrictive pericarditis. The square root sign in both the right and the left ventricular pressure tracings is absent in patients with tamponade, whereas it is one of the important findings in patients with constrictive pericarditis. Now let's talk about the venous waveform. I talked about absent Y descent in patients with cardiac tamponade versus a prominent Y descent in patients with the constrictive pericarditis. Before we get into the explanation of these changes, let us study the jugular venous waveform. The jugular venous waveform has A wave, C wave, X descent, V, and Y descent. And if we correlate these changes with the mechanical activity in the heart, this is how it follows. With the atrial contraction and forcing of the blood into the right ventricle, we have the sudden rise in jugular venous pressure. As the atrium relaxes, the pressure comes down. When the ventricular contraction begins and pushes the tricuspid ring into the right atrium, we see the C wave. As the ventricle continues to contract, its size becomes smaller and smaller, which gives more space for the atrium to expand, and that results in the Y descent. As the venous return from the superior and the inferior vena cava comes to the right atrium, there is gradual increase in the right atrial pressure. When the tricuspid valve opens before the atrial contraction, we see the Y descent, and after that, with the beginning of the atrial contraction, we have the next A wave. So this is a jugular venous pressure waveform. In patients with tamponade, the Y descent is blunted. In patients with constrictive pericarditis, we see prominent X and Y descents. This is an important finding in patients with constrictive pericarditis. Here's an example of a venous pressure tracing. Here we see the A wave. The C wave is almost blunted. Then we have the X descent, and we have a very prominent Y descent in the jugular venous pressure in a patient with the constrictive pericarditis. Here is a phonocardiogram showing the opening of the tricuspid and the mitral valves. Here is a representation of the closing of the aortic and pulmonic valves. Now let's talk about the paradoxical pulse. Normally, during inspiration, the blood pressure drops by about 10 millimeters of mercury, whereas in patients with constrictive pericarditis, the drop in blood pressure is greater than 10 millimeters. It is more like 20 millimeters of mercury, and this may be an important bedside clue for hemodynamic evidence of constrictive pericarditis. In the cardiac catheterization lab, when we put catheters in the right ventricle and the left ventricle, during diastole we see a rapid descent followed by a plateau because there is no more filling of the ventricle after the early diastolic filling that results in what is described as a square root appearance, which is characteristic of constrictive pericarditis. Now let's look at echo and Doppler findings in patients with the constrictive pericarditis. Echocardiogram is an important hemodynamic indicator of how significant the constrictive pericarditis is in terms of restricting the diastolic filling of the ventricle. As you know, the cardiac output is based on the left ventricular filling volume and left ventricular filling pressure. If there is decreased left ventricular filling, there is reduced stroke output, which leads to reduced cardiac output. So let us look at some of the things. Here are some of the changes that we can see in patients with the constrictive pericarditis. On an M mode, we see a double notch in the septum, along with thickened pericardium, which beyond the posterior wall of the left ventricle, and there may also be associated increased size in the inferior vena cava and the hepatic veins. Again, we can see a double dip in the septal motion, along with increased thickness of the pericardium and respiratory changes in the septal motion. Let's talk about mitral inflow Doppler findings. This is an important element in terms of determining the significance of hemodynamic compromise that we see in patients with the constrictive pericarditis. Mitral inflow pulse Doppler along with the tissue Doppler will give us a lot of information about the status of the diastolic filling in patients with the constrictive pericarditis. The mitral inflow, an exaggerated E to A ratio. There is a short deceleration time, that is the diastolic time, and we see exaggerated respiratory variations in E wave velocity of greater than 25%, along with small A wave due to limited filling of the ventricles during atrial contraction. We may also see expiratory increase in diastolic flow reversal in hepatic veins. So let's look at some tracings. Here is a chart showing the differentiation between restrictive cardiomyopathy and constrictive pericarditis in terms of Doppler studies. First, let's look at the mitral valve pulse Doppler. In patients with constrictive pericarditis, there is an exaggerated E wave with diminished A wave. This gets more prominent during inspiration as compared to patients with restrictive pericarditis, where there is actually no change during respiratory cycles. Now let's look at tissue Doppler. Tissue Doppler also shows evidence of a prominent E prime, and we'll talk about that in the next slide. And one more important finding here is the reversal of the flow in the hepatic veins in patients with the constrictive pericarditis. Now here is an echocardiographic finding showing what I was talking about in the previous slide. This is a mitral inflow pulse Doppler showing a prominent E wave, which is evident here, along with decreased deceleration time. And as you can see, the atrial wave is considerably smaller compared to the prominent E deflections we see in the mitral pulse Doppler in patients with constrictive pericarditis. The velocity changes in restrictive cardiomyopathy are less than 25%, whereas in patients with the constrictive pericarditis, the respiratory variation in the E amplitude is very dramatic, and that's an indication that we are dealing with constrictive pericarditis. And here is an actual example of a pulse Doppler from the mitral region in a patient with the constrictive pericarditis, and you can see during respiratory cycle there is a dramatic increase in the E amplitude on the mitral pulse Doppler. The E is considerably taller than the atrial contribution. Now let's talk about tissue Doppler findings coming from the mitral annulus. In patients with the constrictive pericarditis, the E prime increases with the severity of the constrictive pericarditis. The peak E prime could be greater than 8 centimeters per second. And similarly, the atrial contribution becomes less and less prominent because of significantly reduced inflow during atrial contribution. This E prime velocity of greater than 8 centimeters per second is 89% sensitive for constriction and 100% is specific. This is a very important finding to differentiate patients with constrictive features as those without any significant evidence of constrictive features. In patients with should be hypertrophic cardiomyopathy, the E prime decreases with the severity of the diastolic dysfunction, and the E prime is generally less than 8 centimeters per second. Next, we are looking at the blood flow across the hepatic veins as measured by the pulse Doppler. As we can see, there is reversal of the diastolic blood flow in the hepatic veins in patients with the constrictive pericarditis. Also, in constrictive pericarditis, there is what is known as the septal bounce that happens, which can be appreciated in a 4-chamber view, and you can see with each heartbeat there is a reversal of the septal motion in patients with constrictive pericarditis as compared to normal hearts. Here is a chest X-ray showing calcification around the heart, what is known as the axial calcification around the heart, which could be an indication that we are dealing with significant amount of fibrosis and calcification in a patient with an advanced constrictive pericarditis. Here is an MRI of the heart showing a considerably thick pericardium that is encircling the entire heart. That's why I call this like a metal jacket around the heart, which makes it impossible for the heart chambers to expand during early and late ventricular filling. Here is a chest CT showing calcification. Chest CT is very good for identifying calcium in the pericardium, whereas MRI is very good for looking at the thickness of the pericardium and also the texture of the pericardium, which would be quite useful in terms of determining or planning the type of surgery this patient needs. Let's talk about some of the differences between constrictive pericarditis and restrictive cardiomyopathy. We already touched upon some of the tissue Doppler findings. Now let's look at some other features that will help us to differentiate between these two conditions. Pericardium in patients with constrictive pericarditis undoubtedly is thickened, it is calcified, it is fibrotic, whereas the pericardium is normal in patients with restrictive cardiomyopathy. Ironically, the atrial enlargement is very mild in patients with constrictive pericarditis, but in patients with restrictive cardiomyopathy and hypertrophic cardiomyopathy, the left atrial enlargement is significant because of the diastolic dysfunction. The mitral and tricuspid respiratory variations of E waves are greater than 25%, which we already talked about, compared to less than 10 to 15% seen in patients with restrictive cardiomyopathy. Again, ventricular septal motion, which is abrupt early diastolic motion, whereas in patients with restrictive cardiomyopathy, the septal motion will be normal. And the ejection fraction could vary depending upon the overall heart function. Medical management of patients with constrictive pericarditis. In the early stages, when there is no evidence of impaired left ventricular filling, some of these patients may be treated with anti-inflammatory agents and steroids to minimize the amount of inflammation and thus reduce any further worsening of pericarditis. If there is any evidence of fluid accumulation, congestion, and edema, they can be treated with diuretics and salt restriction. Again, weight monitoring will be helpful in seeing how these patients retain fluid. The actual management of a patient with the constrictive pericarditis is a complete decortication or removal or stripping of the pericardium from the myocardium. It is an open heart surgery which carries a mortality around 5 to 15%, and perioperative mortality within the first 30 days following surgery is around 6.1%. The 7-year survival has been found to be worse in patients with radiation constrictive pericarditis, followed by a prior cardiac surgery, where the 7-year survival is considerably better, and you see 88% survival rate at the end of 7 years in patients who have idiopathic constrictive pericarditis. Some of the complications that can result from surgical management could include heart failure, sepsis, renal failure, arrhythmias, and respiratory. So, ladies and gentlemen, this is a brief description of constrictive pericarditis, including etiology, clinical findings, diagnostic tests to identify the presence or absence of impaired diastolic filling, and medical and surgical management. Thank you so much for watching. I am Dr. Nik Nikam, and please do subscribe to our YouTube channel. We will see you next time. Thank you.